Federal prosecutors say a Los Angeles hospice owner billed Medicare for people who were already dead, then moved $15,000 from a hospice account toward the down payment on a lease-to-own Rolls-Royce Phantom. That is the end-of-life business in America, a $31 billion industry where Medicare's current routine home care rate starts at $230.83 per patient per day. The patient can die. The paperwork can live forever. Hospice is supposed to be mercy with a medical license. Comfort the dying. Support the family. Make the last chapter humane. Medicare created the benefit in 1982 and pays a bundled daily rate for care tied to a terminal diagnosis. In 2000, Medicare spent about $3 billion on hospice for roughly 500,000 people. Today, spending is about $23 billion for roughly 1.8 million people. The ownership changed with the scale. More than 80% of hospice agencies now operate for profit. Private equity ownership tripled between 2011 and 2019. And here is the number that should stop you. Well-managed nonprofit hospices have been reported at roughly 5 to 6% margins. For-profit providers, including publicly traded and private equity-owned agencies, have been reported around 18 to 22%. A margin is not proof of fraud, but a gap that large demands a question. What changed for the patient so the owner could keep that much more? The quiet version can arrive wearing the same compassionate logo as the loud one. Original reporting from Washington described a nonprofit hospice's 50-50 joint venture with a private equity-backed company. A longtime nurse said workloads rose from 13 to 15 visits a week to 20 to 25. Workers alleged that some records were falsified or backdated, and that missed visits were sometimes labeled as patient requests when no employee was available. Providence declined an interview for that report, and Compassus did not respond before publication. Those are worker allegations, not court findings. Then come the federal cases. In June 2026, prosecutors charged a Los Angeles hospice owner and alleged that his companies submitted about $27 million in false claims for patients who were not terminally ill or were already dead. The indictment says living and deceased patients' information was sold into the scheme, and that $15,000 moved from a hospice bank account toward a lease-to-own Rolls-Royce Phantom. In another indictment filed in Texas, prosecutors charged a nurse practitioner from Las Vegas in an alleged $906 million wound care scheme that targeted elderly Medicare patients, many terminally ill and in hospice, with medically unnecessary grafts. About $297 million was paid. The government says it seized a $594,000 Ferrari and an $865,000 Bulgari necklace. Those were part of a national 2-week takedown for 155 defendants across 56 federal districts, tied to more than $6.5 billion in alleged fraud. Hospice physician Ira Byock described the broader staffing pressure this way. It's not uncommon these days, particularly in corporate hospice programs, for hospice physicians to be responsible for 150, 200, or even more patients at a time. He called that dangerous. He said a well-trained physician should be caring for around 70. 200 names on one physician's list is not a relationship. It is a census. Here is what Medicare actually pays in fiscal year 2026. For routine home care, the national base rate for days 1 through 60 is $230.83 per patient per day. After day 60, it is $181.94. Local wage adjustments can change the final payment. That daily rate is supposed to cover the care related to the terminal condition, clinicians, medication, equipment, counseling, and support. But the rate is bundled. It is not an itemized invoice for each nurse visit or each minute with a physician. That creates the pressure point. If enrollment rises while staff time falls, margin can rise. Here is what the Otter notices. Most hospice workers are not villains. They are the nurses who stay late, the aides who refuse to rush a bath, and the chaplains who answer when the family cannot find words. They are also the cost line management can squeeze. Good operators answer with staffing. Bad operators answer with volume. Same word on the brochure. Different business underneath. One day, a doctor may tell you that your mother or father has 6 months to live. You will be grieving, exhausted, and handed a list of hospice providers you have never researched. Every brochure will say compassionate care. None will lead with the owner's return target, the physician's caseload, or what happens when nobody can make the scheduled visit. You saved for retirement. You saved so that one day, when your parents needed care, the system would be there. Will it be? And here is where I am going to lose it. You had one job. 1. Make the last chapter humane. Not enroll dead people. Not place medically unnecessary grafts on terminally ill patients. Not move hospice money toward a Rolls-Royce down payment. Not ask workers to cram 25 visits into time built for 15 and then blame the missing visit on the patient. Care for people who are dying. That is the job. And spare me the language of efficiency. A dying person is not an efficiency problem. A nurse sitting beside a frightened family is not wasted labor. An aide taking enough time to bathe someone without hurting them is not low productivity. A physician who knows the patient's name, pain level, medications, and daughter's phone number is not excess overhead. Those are the service. The fraud cases are almost easier to understand. Someone allegedly bills for a dead patient. Someone allegedly buys referrals. Someone allegedly applies an unnecessary product, sends Medicare the bill, and ends up with a Ferrari and a Bulgari necklace. Prosecutors bring charges. Courts decide guilt. There is at least a vocabulary for that. But what do we call the version that stays technically legal? 1 doctor, 200 patients. A nurse's workload jumps from 15 visits to 25. A scheduled visit never happens, and the family is told to call back tomorrow. The brochure still says compassion. The spreadsheet says throughput. If you or I took $230.83 from the register, somebody would call the police. But when a company collects that amount per patient, per day, and turns the last week of a human life into a staffing ratio, somebody calls it scale. No, these are not leads. They are not units. They are not a census target. They are people trying to die without being abandoned. One state audit found 1,500% growth. One federal takedown charged 455 defendants. One hospice leader warned that 200 patients per physician is dangerous. At some point, the pattern is not a rounding error. Fraud can bring handcuffs. Legal abandonment can bring quarterly earnings. That is the accountability gap. Do not put mercy on the brochure and extraction in the operating plan. Do not call it innovation when the innovation is fewer human beings beside the bed. Do not call it hospice when the patient is just the billing event between Medicare and the margin. That is not a failure of the system. That is the system. And that is not hospice. That is a toll booth at the edge of life. $230.83 per patient, per day, until the last day.
All individuals mentioned are presumed innocent until proven guilty in a court of law. The Angry Otter is not a licensed hospice physician, Medicare auditor, wound care specialist, or Rolls-Royce payment processor. Side effects may include elevated blood pressure, auditing every missed visit, and an uncontrollable urge to subscribe.
Like and subscribe to find out who makes the Otter angry next.